Okay.
This started. So I'll introduce you first and then I'll hand it over to you. Okay, everybody, this is Dr. Greg Loeben, and he's a philosopher and a clinical ethicist by training, and he has been teaching medical ethics for the past 25 years. He holds his PhD in philosophy from the University of Arizona, where he specialized in medical and applied ethics, social and political philosophy, and the philosophy of law. He is currently an associate professor and also the practicum coordinator of the MPH program for ATSU University. Dr. Loeben has served on many medical ethics committees, consults with numerous organizations, and has published broadly on medical ethics, and has a long history of speaking to the public and professional groups. So with that, it's all yours, Greg.
Great. Thanks, Marcia. Hello, everyone. Unfortunately, I can't see anyone, which is somewhat disconcerting, but it's nice to know that you're there. If at any point during the presentation something's unclear or you have a question, I think you have to type it into the chat forum. I believe I'll be able to see that, but if not, Marcia, please just interrupt me and let me know. So I'm going to switch to my full screen and get the PowerPoint started. And hopefully everyone can see that now. Okay. So let me give you a quick little bit of background. I originally came up with the idea to explore this topic after a couple of conversations in different contexts. One involved conversations with ethics committee members at a couple of hospitals in the Phoenix Valley. I was serving on those committees. It was around the time of the Ebola scare, the nurse in Houston who became infected, and a couple other instances. And so conversations were taking place about whether we could mandate that medical professionals helped treat Ebola patients or serve in that capacity in the event of a particular individual becoming sick or ending up at that hospital or a larger outbreak. And then a second context was a number of nursing students in a nursing ethics course I teach. One of the conversations that they become most animated about is a dialogue around mandatory flu vaccinations. And I noticed that a large percentage of them were opposed to this, and that the arguments often took the form of it was a violation of their autonomy and a violation of their moral status. It was a failure to respect them as individuals. And so that started to sound a bit like other types of arguments for conscientious objection that I had heard. So I put together a presentation for the American Society of Bioethics and Humanities, and it had this sort of overly long name, Exploring the Ethical Underpinnings of Healthcare Workers' Refusals to Participate, Ebola, Flu Vaccinations, and Conscientious Objection. And I'm a philosopher by training, although I have a lot of time in clinical environments, and I think it's very important to understand clinical aspects of healthcare to talk about the ethical dimensions of it. But one of the things that philosophers do is conceptual analysis. And so this paper, this idea, was more about conceptual analysis. And what that means is I'm not interested in looking at a lot of data, empirical data about people's attitudes. I'm more interested in looking at the meaning of the concepts and trying to unpack those. And I can look to empirical evidence for that. But really, it's what does conscientious objection amount to? What types of arguments are good arguments supporting someone's right to conscientiously object in the context of healthcare? And if we look at arguments that someone might make saying, I don't want to participate in treating someone with Ebola, or I don't think I should have to have a flu vaccination, do those things look like conscientious objection? And why might that be interesting? Because conscientious objection seems to be a category of refusals to participate that healthcare workers can make that there seems to be some professional and social sympathy for. So healthcare professionals are not allowed to abandon patients. Everybody knows that. Their ability to refuse to treat patients or to provide legal services is limited. And conscientious objection seems to be a category or a class in which that refusal is given greater respect. So what I want to do is explore it. One additional preface. Thinking that I already had this PowerPoint together, I waited until Sunday to pull it out, and I was going to expand it in this context for this presentation. When I went to look for it on Sunday, I realized that somehow I had deleted the versions, the completed versions of the presentation. All I could find was an early first draft that had 5 relatively incoherent slides. And I contacted ASBH. I tried to find it as best I could, but I could not. So I basically had to recreate the presentation. And I did not recreate it exactly. In the previous context, I was talking to a lot of people familiar with bioethics and probably to some extent familiar with conceptual analysis. So it was fairly specific in the types of claims it made about the meaning of the concepts. In this conversation, I've broadened it a little bit. We're going to talk a bit about conscientious objection more broadly. Then I'll situate the 2 examples in that larger discussion. I may add something about medical futility depending on how much time we have. This is not going to all wrap itself up neatly. This is a bit more of a, hey, let's explore this idea together. And I'm not going to try to make a very specific, very airtight philosophical conceptual analysis / argument, because I think that would not be as enjoyable for this audience. So with that, let's move on. Hopefully I won't just read everything, and hopefully I won't talk too fast. And I've got to make sure I follow time. Okay, so a number of questions that might right off the bat come to mind. We talk about conscientious objection. I think most people at some level sort of have an intuitive sense of what that means in the context of healthcare. And I think most people probably already have a gut feeling about it one way or another. For example, do you think that a physician should be forced to provide abortions? Almost everybody's going to say no. So at some level you think there should be room for conscientious objection in healthcare because there are certain things that people find so objectionable to force them to do it would be to treat them inappropriately. One of the things I'd like to point out in this discussion is that the idea of conscientious objection is far broader than that. So your initial feeling based on 1 or 2 examples is probably quite limited. So we need to unpack a lot of that in order to get a more sophisticated sense of the terrain. So what is our conscience? How's it formed? What does it reveal? When everybody thinks they have a conscience, what is it that you think is being shown to you when you turn to it? By the way, I'm not going to answer all of these. This is just to give us some idea of the breadth of the general topic. So we think we know what a conscience is, but what would conscientious objection amount to, and what types of things might one conscientiously object to in medicine? Are there limits on that sort of activity that we should be concerned about or that we should endorse? Is all conscientious objection relevantly similar, equally valid? How do we determine if someone's claim is an authentic one? Notice there's a difference here. We might explore ideas about conscientious objection conceptually and say, what types of conscientious objection are worthy of serving as a justification for a person not participating? And notice that's a very different question than asking a question like, how can I tell if the person's claim that they conscientiously object is authentic or is true? Those are 2 different things. And I'm not going to talk much at all about the notion of how we would accurately or adequately determine if someone's claim that they conscientiously object is authentic. But notice that's different than looking at the ethical arguments for why we would respect conscientious objection. Oh, actually, that last one's kind of interesting. To what extent must one be able to articulate the reasoning for their conscientious objection? On the surface, you might think this would just be obvious. If a person's going to conscientiously object, then they have to be able to give a good argument for it. But in point of fact, there are lots of things that people hold and feel very deeply that when asked to explain why, they're not very good at that. So it's not even automatically obviously correct that a person needs to be able to provide solid reasoning for their conscientious objection. Sometimes people just aren't good at that particular skill. So let's try and go a little bit further. What is it? There are many different understandings of what the conscience is, and appeals to conscientious conscience, I guess. It's a little blocked by my face and Marcia's. Seem to be commonly understood as involving at least these two central things. One, appeals to conscience, conscientious objection, involves one deeply held moral or ethical values about right and wrong. And it involves efforts to preserve or maintain one's moral integrity, identity, character, and or self-respect. So in that sense, when someone makes an authentic appeal to conscience, says that I can't participate in this for reasons of conscience, the reason we pay attention to that is similar to broader reasons in medical ethics for why we allow individual choice. And those are often just summarized very quickly in terms of respect for persons and respect for autonomy. So a person who's authentically making a conscientious objection is asking us to respect their authentic decision-making and their firmly held value system. And that's something we take very seriously more broadly in healthcare. Building on this notion, a philosopher, clinical ethicist named Mark Wicclair has argued that conscience-based refusals require a core set of moral beliefs. And the language of moral / ethical / religious can get parsed in a number of ways. I would simply do it this way, that I prefer to use the language of morality and morals to refer to one's personal value system, and a more formal, structured defense of a particular position would fall into an ethical and or a religious type of value system. So you have personal moral values. An ethical system would be one that attempts to defend and justify that position more formally. So an agent has to have a core set of moral values. The thing being refused has to be incompatible with those core moral beliefs, and the refusal has to be based on these core moral beliefs. And this particular article and a subsequent book has gotten a lot of traction in this field. And by the way, one of the other things I want to point out about this talk, for some of you who might not be familiar with bioethics more broadly, that the discipline has a lot of very good academic literature. And so oftentimes when I talk with people about medical ethics, both students and trained professional clinicians who've been working for a long time, they're very unfamiliar with the depth of the literature that's out there. So conscientious objection, if you wanted to look into it, there's a ton of stuff. If you want to look into almost any problem in medical ethics, there's now a lot of very good academic work on it. So speaking of core beliefs, Wicclair goes on and says, quote, one might object to providing a good or service because she believes it would be morally wrong to do so. And yet that belief may not be associated with her core moral beliefs. Accordingly, conscientious objection is understood to be a subset of moral objection. So that's an interesting claim. He wants you to notice that not every type of moral objection is going to rise to the level of conscientious objection. So he's going to, in a full book, lay out a much more thorough conceptual analysis of what types of moral objections actually amount to what we would label a conscientious objection. And I'll touch on this a little later when I talk about professional integrity. Notice there's a line drawing problem here. He's used the language core moral belief, but that's not self-defining. So we would have to attempt to articulate what constitutes a core moral belief. And that's a line drawing problem. But he could have used any other type of language. He could have said something like I did earlier on, that it involves firmly held moral beliefs. That's still a line drawing problem. We still have to spell that out, and that would be the work of conceptual analysis. So what types of practical examples are out there? The familiar ones tend to focus around reproductive rights, reproductive autonomy, end-of-life decision-making, and lately a little bit of, well, I guess it falls into that category, but pharmacy and their right to not fill prescriptions. So things like abortion, withdrawing life-sustaining treatment, PAS, palliative sedation, where you might medicate a patient to the point at which they're unconscious and then not feed them, and so they would die, and people might be opposed to participating in that. Okay. So even more specific examples, in the US, ambulance drivers have refused to transport patients for abortions. Fertility clinics have refused to assist gay couples or individuals. Pharmacists have refused to give emergency contraception to rape victims. Here's a quote: while they have a right to obtain the prescription, as an individual, I always have my own rights not to fill it. So a broad question, limits. How broad a range of belief should be allowed to hinder patient access to legal care? To legal medical care. And as a way of playing off of those last examples, look, we don't want to go into territory and say any type of conscientious objection seems acceptable. So here are some possibilities. Should we tolerate a surgeon who holds a moral objection to transfusions and therefore refuses to order them? Or an internist who says, I'm not going to discuss treatment for diabetes with my obese patients because I'm opposed to gluttony and the behaviors they're exhibiting. Or a primary care doc, or a pharmacist refusing birth control to unmarried women, or Viagra to unmarried men due to a moral opposition to out-of-wedlock sex. So notice these could be articulated as types of conscientious objection if we said that the healthcare professional held a core moral belief opposing these things, and yet intuitively it doesn't sound like we want conscientious objection to be broad enough to cover these types of cases. At least off the top of my head, it doesn't seem that way to me. So it appears the issue is not essentially about moral or religious freedom comprehensively. Now, I want to clarify what I'm saying there. The types of examples I just gave suggest that there are lots of examples in healthcare where someone could make a claim that they conscientiously object to an activity that is something that a patient might think is a normal part of their access to healthcare. And yet we tend to focus on a small subset of those, as I suggested, end-of-life decision-making, reproductive freedom. So why aren't we looking at conscientious objection more broadly? I think if you look at the third bullet point, we focus on issues in which there is deep controversy more broadly socially within the culture, within the society. And I hesitate to clarify that, within the culture. I don't think we have one culture. I think we interact with and are participate in and have many cultures. So let's think of it more broadly as the social structure. But if you look at the types of things that we're interested in passing laws and getting clarification about allowing conscientious refusal, it seems to be issues that are deeply controversial more broadly. So abortion, assisted suicide, reproductive rights for gays and non-married couples, things like that. Just to take this argument a little bit further, or to extend our analysis of conscientious objection a little further, you should understand the idea of complicity. So there have been laws, and there is a push for even more laws, moving us towards carving out legal space for conscientious objection when the provider feels that their participation would make them complicit in an action that they think of as unethical. So a direct relationship would be, I don't want to perform an abortion. A complicit relationship might be something like, I don't want to fill a prescription for emergency contraception because I think that is going to be used by the patient to perform an abortion or to abort a newly fertilized ovum. Now let's leave aside for the moment the fact that that's probably biologically inaccurate. The idea is that the healthcare provider wants protection because there's a chain of events and they're down the chain a little way, but they still think that they're complicit. And this gets a little scary to me. How far down the chain do we go before we say to people that, you know, you're not the one doing the thing you think is problematic, so you don't get to just say any involvement you have in it is enough for you not to fulfill your professional role. So, does the healthcare provider have a right to refuse referral or even the provision of information? So, a healthcare provider might say, if I tell this patient where they can go get that thing, even though I'm not willing to do it for them, I'm complicit in it. And so I want to be able to conscientiously refuse to provide full informed consent or full informed knowledge about what options are available. And in a somewhat dated paper now that was published in the New England Journal of Medicine, I had a better quote, but I couldn't find it again, having to recreate this presentation. Curlin et al. Did a study, and they ended up saying many physicians do not consider themselves obligated to disclose information about or refer patients for legal but morally controversial procedures. Okay, so let's jump into flu vaccinations real quick. Let me see, I don't have Ebola on there, do I? And Ebola, okay. I was reading an article by Leah Curtin, and it was called Conscience, Legalism, and the Clash of Rights. And in it, she wrote, by no means is abortion, gotta move my face here, the only problem of conscience for nurses. In 2015, thousands of nurses across the US received forced flu vaccinations, choosing either to lose their job as a result or endure shame and ridicule for being forced to wear a mask. In the same article, she went on to identify a different article by a woman named Sharon Buchbinder. And she wrote an interesting twist. This Buchbinder said nurses have a right not to care for Ebola patients under some circumstances. So in the article by Leah Curtin, which was in American Nurse Today, she was linking the notion of mandatory flu vaccinations and Ebola with the idea of conscientious objection. She used both the language of conscientious objection and the language of rights. And writing about being told to care for Ebola patients without sufficient preparedness, Ms. Buchbinder, in the article that Leah Curtin was citing, wrote, healthcare personnel are putting their lives and the lives of other patients and their families at risk. If a nurse or other healthcare worker is put into this ethical dilemma, she has an obligation to refuse to care for a patient with Ebola. So, and the title of that article was, Can Nurses Refuse to Treat Ebola Patients? So this was part of what got me thinking about the idea of how similar is this to a form of conscientious objection. So some organizing questions. Can refusals to get a mandatory flu vaccination or to provide treatment to Ebola patients count as instances of CO? And how should we restrict what might count as instances of conscientious objection so it isn't abused as a justification? Or do we not need to do that? Let's look at flu vaccinations real briefly. Some people claim to oppose vaccination due to religious beliefs. Others oppose it philosophically. It's not grounded in formal religious teaching, but it rises to that sort of same theoretical structural level in their mind. Other people oppose them simply because they think of them as unnecessary and or ineffective. And by the way, it scares me the number of nurses taking a medical ethics course in nursing that think that vaccines don't work and that are just fundamentally misguided in the biology and chemistry and public health aspects of vaccination. Some are not opposed to all vaccines, but they're opposed to the mandatory aspect of the vaccination. So another way we might approach this is, could an opposition to the mandatory nature rise to the level of a conscience-based exemption? And again, why do I care if it's a conscience-based exemption? Because that's a subclass that we defer to more regularly. So if people are making arguments that amount to conscientious objection, then they have to be seen in a certain light. Going on with the notion of religious objections, it turns out no major religion explicitly objects to vaccination. However, individual leaders or groups within a religious tradition might interpret texts or teachings in a way that embraces a religious prohibition. So there may be individuals of a particular faith who do view their objection to participating in this type of medical treatment as religiously grounded. And an example could be a Christian Scientist. The church does not have a formal policy against vaccination, but they do have an underlying theological belief that the human body is a manifestation of God's perfect spiritual world. This is what causes many of them to refuse certain types of medical treatment, because the treatment should be spiritual and the physical illness is a manifestation of one's own spiritual failings. A Christian Scientist might take vaccination as violating that type of theological idea. What might we say more broadly? I think we could fairly clearly say something along the lines that many people claiming religious objection to mandatory flu vaccination are in fact not appealing to religious belief. Now, I'm not going to try and give you a method for proving when one makes the claim, because that goes back to how we would evaluate whether one's claim is authentic. I'm simply making the claim here that since most religions do not oppose it, and most people who make the claim that, you know, this is something they feel is inappropriate aren't really spending much time thinking about the theology behind it. I'm just making the general statement that I don't think most people who would make that claim are in fact really appealing to a deep, honest religious belief. Now, that doesn't mean that they don't have a value system that supports their claim. It's probably just not a core religious value, and if so, it's probably not one that would be supported by the underlying faith tradition. At the same time, I think we could make the claim that one can oppose vaccinations in a way that could rise to that level. And we could describe that as a level reflecting deeply held values about right and wrong and one's personal integrity. So off the top of my head, I would say I think the vast majority of appeals to not have a flu vaccination for religious reasons are not forms of conscientious objection, but conceptually they could be. There could be a subset that are, and that's important. Let's look at the mandatory piece for a second. So healthcare providers in general are required to receive other types of vaccinations in order to perform their role. Certainly if they work in certain facilities, it's a precondition of that employment that they receive certain vaccinations. So we might explore conceptually a question. Could one conscientiously object to all vaccinations, but then realize that they need to get some vaccinations in order to get the job, so they willingly agree to some of them, even though they wish they didn't have to take them? Now that they're in the job, conscientiously object and refuse to get a mandatory flu vaccination because they feel it's a violation of their belief integrity. And this seems to me just to be a form of incoherence. It doesn't mean that somebody couldn't make that claim, but it does seem like the idea that the subsequent claim would be a form of conscientious objection is defeated by their previous choice to go against their conscientious objection in the other instances. Now, we don't have enough time to go into a full analysis here. I already recognize problems with what I just said. The fact that I might violate my own conscientious objection in order to secure employment doesn't mean that a subsequent instance of asserting a conscientious objection that's similar to one I previously denied or previously did not uphold doesn't mean that the second one is less sincere. But it's an interesting thought nonetheless. I think practically speaking, we could say that the vast majority of healthcare professionals who have already gotten some vaccinations and who probably aren't appealing to a core moral belief about the immorality of vaccinations, when they assert that they shouldn't have to get a mandatory flu vaccination, are not making the type of assertion that we should consider a conscientious objection that requires the full defense of their autonomy. Do you love how philosophers talk? So let's move on to Ebola a little bit. The claim here under consideration is the idea that refusing to treat a patient with Ebola in circumstances with insufficient preparation, a lack of training or a lack of knowledge or a lack of equipment, that doing those things requires subjecting oneself and or one's family to unacceptable levels of risk. So I don't want to do that because I either haven't been trained properly, I don't have the proper equipment, or the facility hasn't prepared us appropriately. And the risk is that I might get ill, or my family might get ill, or my getting ill will seriously harm my family. Many people could claim that they have a core moral belief central to their identity and integrity, that the well-being of their family comes first. So could that core belief ground a conscientious objection to providing treatment? And revealing a little bit of empirical experience, when I have this conversation with healthcare professionals, many of them are quick to make the argument that they need to protect their family members, and healthcare environments which expose them to risk can seriously harm their children or their family structure. And when they make these arguments, they make them in a way that it sounds like, to me, their identity is wrapped up in that value, that their understanding of who they are as a person is grounded in that moral belief. And so it's coming close to something like a core moral belief, in my opinion. So in situations where they really do lack sufficient preparedness, I think conscientious objection is unnecessary. The grounding of the refusal is based in already accepted norms of medicine. There's already well-established ideas that the healthcare provider's level of risk to oneself is not unlimited, and that there are obligations of the facility to provide appropriate training and or equipment, etc. So I don't think you need conscientious objection for a healthcare provider to say, this environment is unsafe and I don't have to participate in it. And since the reason I was examining whether these arguments rise to the level of conscientious objection was because I wanted to know if they could have that additional level of protection in at least these situations of lack of training or equipment. They don't need that additional level of protection. They already have good normative reasons to say no. And by the way, when I was engaged in those conversations with the ethics committee, we were doing that at the behest of the administration. And so under consideration was what sort of penalties could be doled out to a worker, an employee who said they would refuse to participate. And so a question might be, can we fire the person if they say they're not going to do this? And my answer would be, if you haven't provided adequate training or equipment, then you can't fire them whether they're making a conscientious objection or not. So what about situations where the refusal is not grounded in lack of training or equipment, but ignorance? Remember, I said that there was a lot of ignorance around how vaccines work. Now, there was a lot of ignorance around the threat of Ebola. And what if the nurse involved or another healthcare professional involved said, I'm not going to do that because that environment's unsafe, but they were simply wrong about that information? And we could think about this in terms of uncertainty around treating HIV patients in the 1980s. So actually, let me clarify that because there's two pieces here. One is, suppose they were simply wrong about the level of risk. The other is, suppose that we actually don't know roughly exactly the level of risk. So in the first, there's a failure of training, a failure of equipment. In the latter, there are two versions. One is, we really don't know exactly what's going on here, so there is risk to you, but we don't know exactly what it is. And the second is that the professional just gets the levels of risk wrong. They're ignorant in a certain sense. What can we say about those types of claims? And here I want you to realize my question isn't whether the provider should understand their moral obligations to accept that level of risk or uncertainty. If we can say, oh, your level of risk is 75, do they have to accept that? If we say, well, this is the level of uncertainty, do they have to accept that? That's not my question. My question is whether their refusal to do so can ever be understood as a form of conscientious objection when it's grounded in a sincerely, deeply held core moral belief that the risk to family is too great, when the belief is based on inaccurate factual information about relative risk or uncertainty. So the idea here is they have a core moral belief that their family should not suffer from them being involved in something that's overly risky. They might be getting the risk level wrong, but they have the core moral belief. So can that be understood as conscientious objection, even though they're getting the fact wrong? And let's go a little. So false clinical beliefs. Should assertions of conscientious objection that are based on demonstrably false scientific or clinical information be respected? I think that we could say two things. One, using the standard that the belief, that what makes it a conscientious objection is that it's a core moral belief. One could hold a conscientious objection to participation in a situation in which they have some of the facts wrong. but it's hard to see how personal ignorance of the fact could justify the refusal based on conscientious objection. So go back to the nurse. I'm not going to participate in caring for that Ebola patient because I have a core belief that I should not put my family at risk by participating in environments that are too risky. And that environment seems extremely risky. And we can then point out to the worker that environment is less risky than other things you do regularly, other contagious diseases you work with, other environments in the healthcare system that you participate in. I think that person's no longer got grounds for conscientious objection that would be sufficient to protect them from for their refusal. Whoops, where am I? Okay. Does it matter to if the risk to the family is indirect harm, that a healthcare provider might die or not be able to care for their children? A healthcare provider might hold a deep moral belief the risk to oneself would be morally required, but the risk to one's family violates their conscience in an unacceptable way. Wicclair actually says something about what we've been talking about. He says, healthcare professionals can refuse to provide a good or service for a variety of self-interested reasons, broadly understood to include concern for one's own health and well-being, as well as of persons one cares about. And he goes on and he says, insofar as refusal is exclusively based on these reasons and not on the practitioner's core moral beliefs, it is not conscience-based. So he says, look, a healthcare professional could refuse based on a concern for the well-being of persons one cares about. But if it's based exclusively on this and not one's core moral beliefs, it's not conscience-based. So I would say, what's the argument that preventing unacceptable risk to one's loved ones is always self-interested and cannot rise to the level of a core moral belief? Most parents I speak to, most women certainly, view their commitment to their children and the well-being of their children as a central moral value they hold, and it's constitutive of their identity in some respects. So it seems to me that Wicclair dismissing the notion that one could have a conscientious objection to potential harm to their family or their children is simply wrong. That can rise to the level of a core moral belief. And it's not self-interested to say that I care so much about my family, I'm unwilling to risk their well-being by risking my own health in this context. So what's the take-home from that? The take-home is sort of small. It's that one could conscientiously object to participating in an unsafe working environment based on the concern that it would harm their family. Now, I don't have much time. I guess I have some time. I threw in 4 slides here. I'm not going to present them all. I wanted to link this to one further concept, the notion of medical futility. Medical futility is a type of claim that medicine or medical professionals can make that we don't have to provide a certain good or service because, and there are 2 versions, quantitative or qualitative. Either the odds of succeeding are too low, that's quantitative, or the value of the goal is too low. And I wanted to make the argument that this too could be a form of conscientious objection, that a healthcare professional saying, I'm not going to do that thing that you want us to do because the value of the goal you're asking us to achieve is too low. And I am so opposed to you choosing to do this that me participating in it would violate a core moral belief. So what might be an example of this? I worked the ethics committee at Phoenix Children's Hospital and had been involved in more than one case where parents simply were unwilling to stop providing any type of medical treatment that was available to extend the life of their child, even with children who were going to die in the near future regardless, who had blown out almost every vein in their body so that there was no place to put an IV to deliver the medications that were necessary to alleviate pain and prevent near constant seizures. Healthcare professionals that felt like they were being asked to torture the child based on the parents' choice to do everything. So could that type of, no, I'm not going to do this because what you're asking me to do is not good enough, be a form of conscientious objection? And I would argue that yes, it could rise to that level. And I want to flip that on its head. Arizona passed a law, I don't know if it's still in effect, but it required people being, physicians providing the morning after pill to tell women who were going to use that pill that the results of the first pill could be reversed within a short window of time. And I forget the exact amount of time. This appears to be not scientifically valid. It's not accurate. And yet the Arizona legislature required it. I think a stay has been put on it. So could I, as a healthcare professional, refuse to do that and ultimately make the claim that this was a violation of a deeply held moral belief I had about the proper way to represent medical knowledge or convey the truth to patients or something along those lines? But I don't have enough time to go into all of that. Ultimately, I would say that yes, they can rise to the level of conscientious objection, and that it would involve, look at the third bullet point here, it would force us to look at a range of questions about what view of one's own role does a provider have to have in order for one's belief about that role to count as a core moral belief. So just like a mother might say, I have a core moral belief about the well-being of my children, a physician might have core moral beliefs about their identity that are wrapped up in professional integrity or some version of the accurate representation of medical knowledge. So I'm going to try and move quickly here. We're getting near the end. We've looked at the notions of conscientious objection, and I've mentioned that there is a range and we have to be careful in where we draw the lines. Eva and Hugh LaFollette have written in a number of articles, and Hugh LaFollette's a very good philosophical mind. One might grow up conscientiously opposed to admitting African Americans to white public schools and to letting black and white people drink from the same water fountains. He, in fact, points out that he grew up with those attitudes. And he further states, they further state, not all conscience is created equal. Not all conscience should be treated equally. So look at these real quickly. A vegan who doesn't want to serve meat at Burger King, a fireman who doesn't want to extinguish a fire at a Santeria church, an electrician not wanting to make repairs at an abortion clinic, a policeman not wanting to investigate gay bashing, a public defender who doesn't want to defend a child molester, a real estate agent not wanting to sell a house to an interracial couple. These all are versions of a professional role or an employment role in which the individual says, I don't want to do that because it violates my moral value system. If we're going to allow professional instances of conscientious objection in healthcare, we need to look at how that's consistent across other types of respect for conscientious objection in other professions. And I'm not going to answer all these, but notice when I throw these up, it becomes less intuitive where we should draw the lines in allowing healthcare professionals to say, no, they don't want to participate in that thing because it rubs their moral core the wrong way. So some final questions when we think about different types of conscience and conscientious objection. Is my objection self or other regarding? What is it demanding of others? Is it conscripted or voluntary? How did my being in this situation and need to make this, draw this line come about? So many people choose to go into particular medical professions knowing that they entail certain things, like filling scripts for people who might want to use them for things you don't believe in. Is it more or less important to the one claiming it? How articulatable or defensible is it? How definitive of one's role? How consistent with the goals of medicine? On its surface, is it intolerant, disrespectful, or discriminatory? And how does it match up with one's other beliefs? So some quick wrap up, 2 slides. To the extent that conscientious objection requires refusal based in a deeply held ethical belief, such that performing the act would be a serious breach of personal identity, the number of people justifiably understood as making a conscientious objection claim to mandatory flu vaccination is small, though conceptually there are real grounds for it in some cases, and that might need to be acknowledged and allowed in a policy of conscientious objection. Second, as for refusals to treat an Ebola patient grounded in fear, uncertainty, lack of knowledge, one can see the commitment to the well-being of one's family as a core moral belief. It might entail the refusal is not, this might entail that the refusal is not necessarily grounds for dismissal or sanction, though I don't think that's sustainable when it can be shown to the person making the claim that their claim is based on factually inaccurate information. And last, the issue captured by conscientious objection seems not to focus simply on conscientious objection broadly, because it would cover a far wider range of cases, even just within healthcare, than we normally talk about. So I think it's focused primarily on socially controversial issues. And to be honest, I think it's driven largely by a certain political component as well. The same basic values that support rights of conscience for professionals also limit the scope of such rights. Now, this is a broader philosophical claim that I didn't explore very much, but the grounding for claims of conscientious objection, things like respect for individual autonomy, social rights, respect for personal integrity, those very things are the things that argue for informed consent, full disclosure, patient rights to access legally prescribed medical treatment. So it's a double-edged sword here. Conscientious objection is supported by the same values that limit it. And lastly, while many objections can rise to the level of conscientious objection, this by itself doesn't tell us what forms of conscientious objection we should ethically respect. And so I've made the argument that both mandatory flu vaccination and Ebola, refusal to participate in Ebola, can be forms of conscientious objection, but that alone doesn't tell us where in the spectrum of what counts as conscientious objection these types would fall, and whether we professionally and socially should endorse them as justifiable grounds for a healthcare professional to not provide a treatment or participate in the delivery of care. So that's it. And since I couldn't see anybody's faces, I have no idea if it was moving too fast, too slow, if people are asleep, but I'd be happy to engage any sorts of comments.
Okay. Since Greg was interested in having a conversation here, if anybody wants to actually converse rather than type something in the question and answers or the chat, and to let me know that you want to be up to the, moved up to the panelist view so that you can actually be heard and talk.
So John's written something. I'll read it now, and I'll see what it says and try and engage it. Thank you for an interesting presentation. This is John Fick. It's my understanding the creation application of an ethical decision tree is often used in analyzing similar, albeit not identical, types of ethical philosophical scenarios. Therefore, what role, if any, do decision trees play in these types of decisions? And or what experience have you or an ethics committee had in applying ethical decision trees around this or similar topics? Interesting question, John. So decision trees are helpful to the extent that a lot of the stuff I was talking about today has already been spelled out. I think that I'm doing some work here that is intended to create more branches on the tree. So if an ethical decision tree is an attempt to say to people, start with this, what information is relevant, what's the core question that you're starting with, and then based on answers, move them through relevant considerations. And some of what I was doing today was attempting to spell out and broaden what might count as relevant considerations. More broadly speaking, John, I find ethical decision trees to be a fairly basic stage in one's ethical development as a person doing ethical analysis in a practical or applied way. It's a great starting point for folks that need steps that can use the tree to really slow down their thinking and help them think comprehensively. But when one gets a little better at it, the tree becomes an obstacle and it limits how you might think outside of the box. So just like a healthcare professional might start, and in the early stages, boy, they're trying to remember everything in their training, and they're moving pretty slowly. And then you move on to a more organic, a less serial form of cognitive processing about the pieces that you're paying attention to. The same holds true in ethics. So a good decision tree can be a good tool. Ultimately, it'll probably be limiting. Ultimately, a lot of healthcare professionals probably don't get to the stage at which the decision tree is terribly limiting. But a decision tree is only going to be as good as the considerations that are built into it in the first place. Thanks, John. I know it's difficult to ask questions, even when we're face-to-face. I don't need them. I appreciate you guys attending. I hope that what I had to say was useful. And, you know, just like I said, one of the things I like to do is broaden the way people think about something that they may have initial thoughts about, but we could unpack it more. And this still, there's plenty of room for more unpacking. But hopefully it opened up those doors a little bit for everybody.
Yeah. Okay. Does anybody else have any questions? Does anybody want to talk?
Yeah.
Yes, Helen, let me get you up. Okay, you should be rejoining as panelists now. There you go. Let's get you.
Helen, you're muted.
You're unmuted now, so go ahead.
Okay, great. Thanks for letting me know that. Thank you very much. That was really interesting and really well done. One of the things, having worked on hospital units before and seeing in particular the whole flu objection thing going on, which I would have to tell you was not really well received by other staff members. I guess what I'm thinking about, when I think about a lot of this stuff, I think about where does one person's rights end and the next person's begin? When you're talking about the flu, you're talking about people who are saying, this is my right not to get this, but I'm still going to come and be around these highly vulnerable individuals. I mean, the flu can be deadly. Mm-hmm. And so where does this idea of boundaries, of one ending and the other beginning, how do we think about that in ethical terms? Is there some sort of ethical terminology that fits that?
I wouldn't say there's just some sort of ethical terminology. Like all disciplines, ethics tends to use words in particular ways within the context of that discipline. So I could use words like beneficence or non-maleficence or autonomy and try and spell out what they mean in this particular type of problem we're exploring. But I think more broadly or more deeply, Helen, a lot of people, when they first think about an ethical dimension to an issue, they see several pieces. And so they think, okay, well, you know, we have to pay attention to those. And often what I'll say is, okay, they're good. Now let's take each one of them and push down into it. So for example, a surface issue, and it's an important one, is where does my right to control my medical care as a healthcare professional, and flu vaccinations are a form of medical care, butt up against somebody else's right to be free from a threat that I might pose to them in the delivery of care? Where does my autonomy butt up against the threat of harm to them? We need to then push down into that, and we'll find lots of sub-issues, each of which will then have its own sort of breadth that needs to be explored. So, for example, right away, one thing comes to mind is Hugh LaFollette's question of, how did it come about that you're in a position where this particular type of exercise of your autonomy represents a threat to that other individual? So, broadly speaking, one person's freedom is limited by the harm it poses to another. More specifically, if you've chosen to put yourself in the position where you now are a threat to the other person, your claim to freedom becomes even a little weaker. because you could have chosen to go someplace else, to do something else. Let's look at that more carefully. In certain types of healthcare, that choice is more or less real, more or less reasonable. I choose to go into nursing. I shouldn't have to get a mandatory flu vaccination because I should have control over my body. Well, you chose to go into something where you're working with sick people, compromised immune systems, and you sort of knew that going in, or you should have. But take somebody who works as an OB-GYN. The science of that field has changed so much over the past 20 or 30 years that they're now in a professional career. They can't simply change it. And yet it may be presenting them with choices that they didn't have when they started. So their responsibility for being in that position is a result of a choice, just like it was for the nurse, but the reality of that position has changed. And so we might think that they're less culpable in a sense, and they should have more freedom to make a conscientious objection because that one dimension of their autonomy butting up against the harm has changed. Let's change it a little more. What if it's still a question of autonomy versus harm to another, but the type of thing we're talking about is clearly prejudicial? So I say, look, I shouldn't have to do that because I think it's morally objectionable, and I should have that freedom. But the thing I'm saying that I don't want to do is provide good care for somebody because I don't like their skin color, or provide something that is standard for my practice, the delivery of birth control, to a couple that I don't approve of because they're racially different. In that instance, it's autonomy butting up against harm to others, but we're not sympathetic much at all because there's another dimension, and that other dimension is prejudice or a form of inappropriate bias. So your question to start was, conceptually, how do we think about this line drawing between one's self-determination, one's autonomy, and potential harm to another's? And my answer to you would be, this is why philosophers are relevant to healthcare, because what we're good at is this type of conceptual analysis, this type of breaking things down into the pieces and spending the time saying, how important is that piece? Is that piece something that is being acknowledged? Does it build into John's decision tree or not? And that's a lot of work. And that's where people who care about the ethical dimensions of healthcare but maybe don't have that skill set often find frustration, because we're torn between the idea on the one hand that ethics is just whatever anybody thinks. It's just a matter of personal opinion. And people are quick to say, oh, well, I just think this and you just think that, and there's no real right answer. And on the other hand, slow, careful thinking about the pieces. I use the language about the dimensions of it. And really good work that says this piece matters, that piece doesn't matter. If a person's making this type of a claim, it's more powerful than if they're making this type of a claim. And oftentimes when I say to people to do ethics well, push down into it that way, that's when they get frustrated. It was easier at the surface where they could say, oh, we just disagree, and there's no real right or wrong answer. And I want to say, well, there isn't one right answer, but there are lots of wrong answers, and we have to push down into it to start drawing those lines.
Great. Thank you so much.
Yeah, it's good to talk to you. It's always good to see you too.
I know, likewise.
Okay, we've got a question from Michael LaCourte, and he asks, a provider's commitment is to do no harm. They may conscientiously object to issues they perceive as causing harm. However, as a professional, should you be allowed to do this going into this with eyes open? Does the provider need to step back and place a patient before their own personal ethics or morals?
So great question, Mike. That's basically what this whole presentation and the broader issue is about. A couple of quick thoughts. People in medicine love to use the language of first do no harm. The problem with it is that we do harm all the time in medicine. And so it's not really a question of not doing harm. It's a question of how do we justify harms or risks against potential benefits? Where are the trade-offs? And there's no one place to draw that line. So what we're exploring here is in what ways and what types of instances can a healthcare provider not prioritize what the patient wants and has a legal claim to, and even burden the patient to some extent in order to prevent an equal or greater harm to the healthcare provider. And when you start exploring that, it becomes a question of what Helen and I were just talking about. What are the details? And I sort of lost my train of thought. I had one third point to add on to that. Can you repeat that question real quick, Marcia? It'll pop back into my head.
Sure. The question is, a provider's commitment is to do no harm. They may conscientiously object to issues that they perceive as causing harm. However,
so you can stop. So the other point, Mike, was something like this. In order to justify the type of conscientious objection that we would allow, we often pay attention to its burdensomeness on the one who is being denied. So pharmacists have made a lot of noise and gotten legislation passed that suggests they don't have to fill scripts that they are uncomfortable with. And I don't mean to say that too cavalierly. In the ensuing discussion, one of the types of considerations is, how do we minimize the burdens on the person who is not getting the script filled? And so it becomes easier to justify a form of conscientious objection when it occurs in a busy pharmacy and they have a policy in place and multiple pharmacists on every shift. So all that has to take place is the one who doesn't want to do it goes into the back and someone else comes forward and fills the script. Very little harm has occurred. Very little harm, if any, has occurred to the person trying to get that script. Alternatively, if you're a pharmacist in rural America and the next closest one is 2 hours away, and you say, I'm not going to fill that, there's a greater level of harm. And so maybe the conscientious objection is no longer justified. Maybe it depends on the nature of the conscientious objection. If my conscientious objection is that I don't believe in filling the script for an emergency contraception, but I'm the only person who can do it for a very long distance, it's an important type of conscientious objection, but it's outweighed by my professional obligation because it would be too burdensome to the patient. But a different type of conscientious objection could be somehow greater, and the ability of the patient to fulfill it could still be burdensome, but not as burdensome, and we would allow the conscientious objection, even though it still imposed a greater level of burden on the patient. So your question, should the provider have to step back anytime there is a potential harm to the patient that their conscientious objection is creating? I think the answer is no, because not all harm to patients is equal, and not all violations of one's personal integrity on the other side are equal. You could have a serious violation of the professional's integrity and a relatively small harm to the patient. And I would want to argue in defense of that CO.
Okay, do we have any other questions from people? Does anyone else want to speak?
Thanks, everybody.
Yeah.
Have a good day.
Thank you. Thank you.
Take care, Marcia. Good to see you.
Good to see you. Okay. Bye-bye, everyone. Thank you for attending.